Just to give you a brief introduction, Common Health is a multi-state coalition of both individuals and organizations working specifically in the area of reproductive health and maternal newborn health and safe abortion. Our vision is to ensure a society that ensures maternal newborn health care and safe abortion for all women, and specifically for women from marginalized communities. And our members are diversely located across the country, but also come with different areas of expertise. We've been working now for a little more than a decade, and our strategies, I think, have been mainly two-pronged. The first is that at the national and at the state level, we look at ourselves playing what we call an agenda shaping or a discourse influencing role. And by this, I mean that we try to bring in a lens of gender and rights into the area of reproductive health. And this we've been doing through engagement with policymakers, through research itself, through action research, through putting out concept papers, engaging with the media, etc. The second strategy has been to work at the grassroots with generations of advocates by mobilizing them, enhancing their capacity, and bringing in a gender and rights lens into their work on maternal newborn health and safe abortion. So in this particular presentation, I'll be drawing on the work that Common Health has done in the area of maternal health, safe abortion access, and specifically I'll be drawing on 3 initiatives that we worked on. So the major part I'll be talking about is the Dead Women Talking process. I'll talk a little bit more about this, and then briefly I'll also be touching on 2 other initiatives, one that we did in Gujarat on monitoring quality of maternal healthcare services, and then the second is the Creating Common Ground initiative. I'll talk a little bit more about that later. But before we go into the initiatives itself, I just want to state here that the perspective from which we come and where we've been working with. First and foremost, we see maternal and reproductive health as a right. And social determinants as important contributors to reproductive health, and gender itself as a very key determinant of reproductive health. The other thing that has been very critical to us is the women-centeredness of our work, that we foreground women's voices, and that has come up again in Vandana spoke very eloquently about voice and participation, and I don't know whether we've been, I won't call ourselves successful all the time, but we've constantly been aware of this and have tried to engage with that. We also see community participation, women's participation as a value, and community mobilization as a particular strategy towards our vision. So moving on, this Dead Women Talking initiative, there are many in this hall here who are familiar with this and who have also been part of this initiative. So I'm drawing on from this collective work that many of us have been part of. This was a collaborative civil society initiative that involved several organizations across the country. All of these were either community-based organizations or organizations that worked closely with different communities. And all of them came with a rights perspective to their work. Now, as part of this initiative, we documented maternal deaths across 10 states over a period of 2 years, across specific geographic areas of 10 states. And this work came from an understanding from the earlier work that we'd been involved with. And that was that maternal deaths affected disproportionately women from marginalized communities. This came from our earlier work, and also there is evidence pointing to this. That social determinants and health system issues were key contributors to maternal deaths. And we framed the whole issue of maternal deaths from the perspective of accountability of health systems, and saw that as an important, again, key piece in addressing maternal deaths. So I won't be going into the details of the process itself, but I'll briefly just say that as part of this initiative, we documented maternal deaths through what we called social autopsies, as kind of opposed to the general verbal autopsies that is recommended by WHO and the Government of India as part of its maternal death review process. These social autopsies were done by people in the community, so community representatives of community-based organizations, community leaders, and the idea was to identify gender and social issues that contributed to maternal deaths in addition to health system factors that were contributors. And we saw this as complementing the official maternal death review process that had been put in as part of guidelines by Government of India. And one of the key things that we were very we made a very clear effort on was to integrate this with follow-up action. So each maternal death, we tried to actually combine that with follow-up action to address some of the contributors that came out of that. Now, I'd just like to juxtapose this to the government-led maternal death review, or as it is now called, the Maternal Death Surveillance and Response System. Now, at the time when this initiative was happening, government reports indicated that though all maternal deaths were supposed to be reported and reviewed as part of this process, less than a quarter of deaths were actually being reported. As to the total number of estimated deaths, less than a quarter were actually being reported. And even with the small number that was being reported, only 2/3 were actually reviewed as part of this MDSR process. The whole process of the government maternal death review was nested within the health system. So the reporting of the death, the review of the death, the analysis of the contributing factors, any action was done completely by healthcare providers, and there was really no scope for independent participation. There have been new guidelines by the Government of India last year. I don't think they have been put into practice anywhere in the country, but some of this has been addressed in these new guidelines. But this was the case when this initiative was happening. The other thing was that there was really no information about the maternal death review process that the government was doing in the public domain. So we really had no clue about what percentage, even this thing about what percentage of deaths were being reported, reviewed, what came out of the analysis, what action was being done. Nothing was in the public domain, and therefore there really was nothing to hold the government or the state accountable to and say, therefore what? And the focus was, from whatever information we had, the focus seemed to be largely on only biomedical causes and not beyond. So as part of this dead women talking process, what did we do differently? And I want to look at this under two heads. One is how was the process different? And second, how was the content that came out of the documentations different? So in terms of differences in process, I think one of the key things that this did was this widened the actors who were involved in the process of documentation of maternal deaths. And this was because the community was involved in different stages of the whole process. So the reporting, the review of, the documentation of the death itself, which was done again by community-based representatives who were trained. The analysis of the death was again done at the local level. So we saw this as a way of democratizing the whole process of documenting maternal deaths and acting on it, and building community accountability for it. The analysis was done through a framework that we developed for this called which we call the SSSR framework, where each death was actually analyzed across 4 domains. The 4 domains were what we call, the first was the science factors, or what was the biomedical, clinical, factors that went into that contributed to the death. The second was health system factors itself. The third was the social issues that the social determinants that were behind the as contributors to the death, and then looking at it from a human rights lens. The other key thing where the process was different, like I said earlier, was that we tried to build an action. And so the documentation of each death and what came out of the analysis was fed back at different levels. And I see feeding back to the community as a key here. And we try to do this through different spaces. So we did this through formal spaces. So the death was actually discussed in the Gram Sabha, which is the local government council. We also used whatever spaces were available, so women's groups, women's Sangathan meetings, so self-help group meetings, so any space that was available, the results we tried to feed back to the community. And what this resulted in was that it helped facilitate some level of community action towards addressing some of the contributors. We also tried to feed back the results to the health system, I would say not very successfully, or with varied degrees of success in different places. We tried to use formal spaces like the maternal death review committees that were supposed to be set up, but we were not very successful in that. And sometimes we had to create spaces like public hearings, but then that came with its own caveats of the credibility and legitimacy of that space being questioned, so that happened. So to kind of look at it, I think the key differences in process were, one, the whole that who were the actors who were involved in the process, what were the things that were being looked at in terms of the analysis itself, and then the whole action that was that we tried to integrate into it. So moving on to content, I think because of the difference in the process and the fact that we tried to use a social autopsy tool and an analytic framework that specifically looked at social determinants, the content that came out was not limited just to biomedical issues, but highlighted social determinants. And some of the things that came up and that we specifically had tried to identify as part of the tool itself were issues of marginalization and exclusion, so caste, poverty, the whole intersection of religion, geographical exclusion, and how these affected maternal health and healthcare. Determinants like nutrition, gender, migration, and how these influence maternal health. So I'm sorry for the slide, which is just a snapshot of a documentation. I'm not going to read through this, but just to say that this is a case from of a woman who died in Assam, which was documented by one of Jenny's partner organizations. And this very movingly actually documents the case of this woman who died after delivering at home and having excessive bleeding. But then the whole thing of landlessness, not being able to afford healthcare when she had a complication in pregnancy, having to sell a cow, in fact, to access some healthcare, even then not being able to access formal healthcare but having to go to an informal practitioner. And the whole geographical thing of, being cut off by the river, not having transport access to actually reach a health facility. So some of these were issues. So these were the kind of documentations that came up. The other difference in content was that we were able to look at health system issues, but look at it from beyond the linear 3 delay model, I would say. So it was, we were able to trace the complex pathways that actually led to the death, and we were able to look at health system issues from the woman's perspective, from the woman's lived experience perspective. And I think that was again key. And this brought out intersectoral issues again like migration, livelihoods, roads, transport. Again, another documentation from Uttar Pradesh of a woman who died of tuberculosis in pregnancy. Again, here issues of migration, food security, access to contraception, and then the very siloed nature of tuberculosis care and then maternal health care, and both not intersecting at any point and not talking to each other, and then resulting in the death of the woman. This is one of our extreme cases that we had documented from a tribal district in Gujarat, which documented the case of this woman. Again, history of seasonal migration, past history of tuberculosis, several pregnancies, an Adivasi woman who then in a late pregnancy was probably suffering from what the story indicated, severe anemia and resultant cardiac failure, and then had to actually travel over a period of 5 days to 7 different facilities back and forth, back to the facility and home, and each of these facilities she did not receive care, and then finally the family decided to bring her back home where she died. This was one of our extreme cases, but we did have several cases where many of these issues kept coming up again and again. And the other difference in content, I think, that this initiative kind of managed to do was because we brought in the human rights lens to the whole issue, and I think that helped us move the issue from beyond a biomedical cause to actually looking at the contributors and social determinants behind it and frame it from the angle of accountability and enforceability. So bringing in the human rights lens. So moving on, I'm just going to touch on 2 other experiences that Common Health has worked on. One is from Gujarat itself, where over the last few years we've been trying to, we are part of an initiative where we've been monitoring quality of maternal health care. And this is being done in 3 districts, 2 of which are predominantly Adivasi districts. And in these districts, we've been working with Anandi, which is an organization supporting Sangatans of Adivasi women. Now here, when we say we've been trying to monitor quality of maternal health care, what we've done is not look at is to look at maternal health care not just from the point of technical quality, but also define quality from the woman's perspective. So what do I mean by this? We actually had discussions with women in the villages, in group discussions, and asked them what they considered a safe delivery, and picked up some of these indicators that came out of these discussions. did an exercise with them to actually rank some of these indicators and then put them into a tool. So the tool which was then administered to, which was done by community-based representatives, so women from the Sangathan leaders actually went and administered the tool and collected information on each pregnancy from pregnant women. Which was then compiled into a block level report card and then shared back with the community. So this is a poster that came out of that initiative where you can, so if you actually look at this says what is, this is in Gujarati, so with my rudimentary knowledge of Gujarati, it says what is a safe delivery, correct me if I go wrong, what is a safe delivery, and in the center, if you can say, it frames it as a right, it says it's my right, and then shows what are these different components. So there are several technical components here, so you can see there in the center there's blood, there's ambulance, on that top right hand corner you have somebody measuring a blood pressure, all of that is there, but in the center you can also see food, you can see access to water, you can see functional toilets. In this corner here you can see a mosquito net, which is a malaria endemic area, and this came out as something that was very important to them, that the hospital have a mosquito net, a bed with a mosquito net, and then a birth companion to be allowed with the woman. So many of these actually came out of discussions with these women, and these were then integrated into the tool that we used. So I'm also going to now move on and touch on another initiative briefly, which we call the Creating Common Ground initiative. Now, Common Health has seen safe abortion access as an important and integral component of maternal and reproductive health, and this again comes from our understanding of who are the most vulnerable with respect to access to safe abortion, and again from the work that has been done by the organizations that have been part of Common Health. These are the most vulnerable women in terms of their age, very young women, single women, women who live in geographically remote areas, who have the most issues with actually access to safe abortion. In some of the states that we work in, we've also had this whole thing of the campaign against sex selection actually acting as impinging access to safe abortion. And so we've tried to look at both of these issues together and create a common ground, and that's where the title comes from, where we've tried to frame both the issues of access to safe abortion and the issue of sex selection as both coming from the root of gender discrimination. And then therefore build capacities of people working at the grassroots to address both of these issues simultaneously from a gender and rights perspective. And that's the framework we've used, where we see both these issues, sex selection and safe abortion, as being overarchingly kind of determined by issues of gender discrimination and the various determinants of patriarchy, son preference, the whole demographic goal kind of push, and then the whole reproductive rights kind of framework. So what have been our learnings and challenges from this all of this work that has happened? And I'm going to look at this briefly from two levels. One is at the community level, and second is at the health system level. Now, at the community level, when we work with marginalized communities, I think there is a great need to demystify what the technical biomedical aspects of maternal and reproductive healthcare are, and these definitely require knowledge inputs, but also need to go hand in hand with pedagogical innovations, because we are then working with women who may have very low educational levels, and therefore the pedagogy that we use to actually kind of look at these knowledge inputs is important. But I think it is also key to place these knowledge inputs not in a kind of neutral environment, but rather put it into a rights framework and use that perspective when you actually look at some of these biomedical aspects. And I think that again came up when Vandana spoke this morning. But again, I think this needs to go hand in hand and be integrated with women's lived experiences, and that needs to inform the community engagement and mobilization that we are working with. And we again need to remember that these experiences will be context specific. They need to be an integral part of the framework, and there needs to be an iterative process where there is constant engagement with the local community to bring in these lived experiences. So knowledge with not in a neutral kind of space, but with a rights framework, but also kind of integrating women's lived experiences into that. And then, of course, gender as a determinant, which then plays out plays out in different ways, both within the household and in the local community, and results in several kind of, factors and contributors. I want to spend some time on this, on how this actually influences our methodology. The methodology, of course, has to be contextually relevant. I talked about pedagogical innovations. But I think we also need to be constantly aware of the power dynamics in any of the research or the engagement that we that are there when we engage with women who come from marginalized communities. And this plays a big role in who collects the information, on whom, how, who analyzes the information, how is it fed back, who acts on it. And I think there is a power hierarchy in each of these steps, and we really need to be aware of it and reflect on it, so that we kind of, there is this very fine balancing act that we need to do between facilitation and actually taking over of the process itself. And that's a thin line, and that needs to be very, very clearly reflected on constantly, and we need to be wary about that. We face several challenges when interfacing with the health system, and this is my last slide. One is, of course, that there are really no institutionalized spaces to engage and interact with the health system, and we often end up creating new spaces. I spoke about public hearings, but that comes with its own set of challenges. We have had these public hearings where the whole credibility of the process was challenged because it was done by, who are you to collect this data and what do you know about maternal deaths. Access to information from the health system has been a major issue, even with tools like the Right to Information Act. There is always a questioning of legitimacy and validity, and that is used as a self-protection mechanism by people within the health system, and there is often backlash to such processes. And even when there is some action, this action is not in terms of system improvement, but largely tokenistic, and there only it's only the lower level staff that faces punitive action. And when we talk about marginalization power, we also need to be aware of how this plays out in this context. And there is also definitely there are inherent power hierarchies between communities and health staff that also kind of inform this.